Okay, thank you for joining this panel discussion. And if you like to take your seats, I think we are ready to start because I don't know how can we manage with the time because yeah, so it is reduce the time, but maybe we can reduce a little bit the lunch time. And okay, great. I believe that we have already heard about some important ethical issues regarding our topic in the previous lecture. The speaker and also the moderator, Dr. Farsalinos, raised a lot of issues about lying and misinform the audience, etc. But this is a panel that it is focused on ethics matters, especially ethics and harm reduction perspectives in tobacco control. I will be the moderator of this panel. My name is Vidalis, and I am a member of the European Group on Ethics in Science and New Technologies of the European Commission, and also a senior researcher working at the Hellenic National Commission for Bioethics and Technoethics. Just a few words, I believe, allow me to say a few words about, for our panelists will refer also only to some selected parts from their CVs, and of course more information about their outstanding work and scientific presence you can find on the conference website, of course. First of all, we have the honor to present Professor David Sweanor from the University of Ottawa. Professor Sweanor is the chair of the Center for Health Law, Policy and Ethics, and an adjunct professor of law at the University of Ottawa. His primary area of work has been the interaction of law and economics as a determinant of public health. And recently, much of his time has been focused on appropriate policies for technologies that can significantly reduce risks and promote health. And then we have with us Professor Panos Vardas, who is chairman of heart sector at the Aegea Hospitals Group, and past president of the European Society of Cardiology, the visiting professor at the Imperial College in the UK, and a chief strategy officer of the European Heart Agency in Brussels. You all know already Dr. and Professor Farsalinos, who just a few words from, he has published more than 85 studies and articles in international journals about smoking, tobacco harm reduction, and alternative to smoking nicotine products. He's a senior researcher at the University of Patras, adjunct professor at King Abdulaziz University of Saudi Arabia, and also he's a professor at the School of Public Health of the University of West Attica. So that's a few words from the CVs, and now I believe that we can start with the presentations. A brief presentation of 10 minutes, please, just to enable the audience and the audience online also to pose questions and to develop a discussion, useful discussion, I believe, and interesting. So, Professor Sweanor, the floor is yours.
Well, thank you very much. It's a pleasure to be able to talk about this topic. And I mean, to try to put it into perspective, mean, the whole area of ethics in public health is incredibly important. You know, when we talk about ethics, we're talking about issues like truth and justice. They're really important because if we don't believe the information that's coming from public health authorities, bad things happen. And we've seen that with COVID. We've witnessed it on many issues, and we're certainly witnessing it on issues of nicotine. And there's a tendency within public health to tell noble lies. Like we're willing to lie to people because we think it's for their own good. Sort of the way a parent might lie to a child that, you know, you need to go to bed or the boogeyman's going to get you, or and thinking that it's all right to mislead people for good purposes. And the result of that is, as Peter Sandman has said, he's probably the world's leading expert on risk communication, formerly at Rutgers University, that we end up with a public health establishment that's often saying, why don't they trust us? And the real question they should be asking is, why aren't we trustworthy? And before COVID hit, there was research from the Wellcome Trust in the UK that had been going on for some time, looking at levels of trust in government health communications globally. And what you found is that in many countries, about 40% of the population, in the case of the US, 40% of the population did not trust government health information even a bit. They just didn't trust them. And Sandman's argument is it's not because they've been misled by somebody else into not trusting these authorities, it's that the authorities destroyed their own credibility by having misled them before. So they're not trustworthy. What can we do in order to try to deal with that? Well, there are ethical frameworks for public health. You know, lots of public health agencies have published these, lots of researchers have looked at them. I think there's a great one by Nancy Cass that was in the American Journal of Public Health about 20 years ago that said, if you're going to have an ethical framework, you need to have something that identifies the health goal. What is it you're trying to accomplish? You need to evaluate the effectiveness of the programs that you're enacting. You need to identify the burdens from these programs. Like, what is it imposing on people? You need to try to minimize those burdens to the extent that you can. You want to have a fair distribution of the burdens, like not inconvenience or disadvantage a select group of the population unnecessarily. And you want to make sure that those burdens end up being fairly balanced. And if we look at this in terms of what's happened on issues of nicotine and tobacco, I think we have a clear failure on issues of ethics. And if we look at that sort of framework, you know, what's the goal? What are we trying to accomplish when we're dealing with issues of tobacco and nicotine from a public health standpoint? And it's not clear, because some people are saying the goal should be a public health goal. You're wanting to reduce harm to the overall population as best you can within an ethical framework. I mean, you know, clearly you could reduce harm by threatening to shoot everybody who doesn't do what you say. That's not ethical. You have to say, our goal, we've got cigarettes causing 8 million deaths a year. How do we reduce that as rapidly as we can in ways that are consistent with human rights, human respect? But others are saying, no, the goal is a moralistic goal, or the goal is to attack the industry, or the goal is to attack all nicotine. And this is common in public health. Alan Brandt talks about it in a book on the history of venereal disease in America, saying there's this constant tension between those who are on a scientific, pragmatic public health agenda and those who are on a moralistic one. And we see this on many issues where this debate comes up, whether we're talking about the war on drugs or sex education, alcohol policy, nicotine. Is it a moral quest, we're fighting sin, or is it a public health quest, we're trying to improve health? We have to agree on that goal. And then when we look at effectiveness, we have to be able to evaluate our strategies, to constantly look at, is this working? Is this the best thing we can do? What we're trying to do is do good better. Are we getting to where we need to be, and be very brave in saying some of the things we've done may not have been as effective as we thought they would be. And we have an absence of that in tobacco control. Questioning dogma in the field gets people in trouble. So to point out that some of the things we've been involved with, and I've been in the forefront of a lot of them, having been the first lawyer in the world to start working full-time on policies to reduce cigarette smoking. Some of the things I was involved in, some of the things we sincerely thought would work, weren't very effective, or something would have been much more effective. But to talk about that gets people upset, because they're saying, well, but you're giving ammunition to the bad guys. Well, it isn't about fighting bad guys. It's about reducing death and disease. We want something that's going to be as effective as possible. When we look at the burdens, so the policies that we bring forward, are we creating burdens on some people? And are those burdens like socioeconomic burdens? So people with mental health issues are disadvantaged when we do things like put up the price of cigarettes because we think it's going to cause everybody to quit, but the people who don't quit now don't have sufficient money to buy food or lodging. That's a burden. We have burdens like coercion to say, is the best way to promote health to try to force people to change their behavior? And public health talks in very different terms. We talk about empowering people to make better decisions about their own health. It's not about saying, I forbid you from doing something. It's about, I'm going to encourage you to do something you want. So the idea of saying, I'm going to be at your house at 6 o'clock every morning to make sure you go out jogging, and I'm going to punish you if you don't, isn't public health. Saying the city's introducing better pathways for jogging if jogging's something you want to do. That's public health. We use an awful lot of coercion in tobacco control. We don't do very much in terms of empowerment. We destroy trust by not giving the people the information they need to make those informed decisions. And there we are doing things that fail to give people sufficient information to make an informed choice, like convincing people that nicotine causes cancer or that vaping is as hazardous as smoking. And then we hold them responsible when they get sick. Well, you should have known better. If you got lung cancer now, it's your own fault. It's not within an ethical framework. We're putting a burden on people unnecessarily. And when we look at how you minimize those burdens, because everything we do is going to have different impacts on different people and will create some burdens, what do you do to give people viable options? So you're putting up the taxes because you think that'll discourage young people from starting smoking and get other people to quit. What are you doing for the people who are not going to be able to stop using nicotine? Are you giving them alternatives? Is there something else there? So like putting up the price of petrol, but saying, but we're going to have cheaper fares for public transit. You're giving people an option. What about differential taxation or pricing, the way Sweden did with snus, to say cigarettes are going to be expensive, but a can of snus will only cost half as much as a pack of cigarettes, and a can of snus lasts twice as long as a pack of cigarettes. You're giving people somewhere to go. The provision of truthful information to minimize burdens, to let people know what they can do. Again, empower them to make better decisions about their own health. And understanding their lived experience. So give them options that are viable to them. Don't give them options that we think are a good idea. Give them the information they need for them to do something that they think is a good idea. When we look at, is this overall policy fair, how do we deal with the huge inequities that we have? It's not fair. How do we try to redistribute the burdens in a society from these policies so that we get something that's fair, that people actually start trusting us, that we're not disadvantaging people? And we're not doing that. When you look at how many people are smoking cigarettes without a viable alternative, when we look at countries that do give partial alternatives, as Konstantinos was mentioning in the previous panel, Japan, 40% or 50% almost reduction in cigarette sales in just 6 years by them having heated tobacco. But they don't have snus, they don't have oral nicotine pouches, they don't have vaping products, they don't have differential taxation to give a big advantage to these products, they don't have massive education programs. And that's one of the standout countries. What would happen if we empowered people. Again, an ethical framework to say we're trying to reduce the burdens on the overall population, we want them to have more options. And how do we move from coercion to empowerment? And if we do those sorts of things, I think we're looking at an ethical framework and we have the ability to accomplish great things. We're not there yet. Thank you.
Oh, thank you very much. It was great intervention. So, Professor Vardas, it's your turn now.
Okay, great. So thank you very much for your invitation. And I would like to start this short discussion with a declaration. I'm fully aware as a senior cardiologist that I'm talking about a very sensitive issue. Smoking, tobacco harm reduction, and ethics. Second, I would like to declare that what I'm saying here does not represent the official view of the European Society of Cardiology, either in Brussels or in Nice, and just I'm expressing personal views. Great. And then I would like to remind you that ethics and ethos, it is really Greek words which were developed here in Athens. And we have, talking about ethics and ethos, we have to be extremely sensitive, conscious, and no doubt, to be sincere. Even if we are wrong, at least we have to be sincere. Be sure that what I'm saying here express my real view. According to WHO recent views, human being nowadays should be refrained from smoking, full smoking cessation and absence. Human being should not consume any alcohol. This is the official point of the WHO, that even alcohol, 1 glass of wine per day, could be harmful. And to a significant degree, human beings should reduce salt. This is the ideal opinion of WHO. And also, if possible, you have to walk about 10,000 steps per day. You see, because the smart watches now, we have a new understanding about how much steps we are walking every day. That was impossible some years ago. Let's be a little bit more realistic now. I would like to point out that, fortunately, human being, thousands of years, is a hedonistic being. Human being likes the pleasures. Human being does not like the unpleasant situations. Sometimes these pleasures are risky, of course, but in general, human being likes the pleasures. So what?
Particularly in Greece.
Yeah, but in my opinion, as I am an international citizen, I haven't seen significant differences between the human beings in different countries.
Sure.
Possibly they are looking a little bit different, but anyway,
Yeah.
in general, human being is a hedonistic being.
Sure.
Now, so what a cardiologist, a senior cardiologist like me, Chief Strategy Officer of the European Society of Cardiology, is thinking about this dilemma? Complete smoking cessation or, to some degree, alternative ways to think and to practice? Dear colleagues, more or less, the same dilemma is faced by the Catholic priests in Africa. You know, the Pope in Rome is absolutely against the condoms, 100%. This is the official doctrine of the Pope. However, as far as I know, priests in Africa are facing huge and practical dilemmas as AIDS is rocketing, and the sensitivity of these human beings, the priests, is getting alarmed because these indexes of AIDS, they have to do something to stop this epidemic. Against even, sometimes, theoretically, of the doctrine of the Pope. So more or less here, cardiologists are facing the same problem. No doubt, for us, the holy grail is the complete smoking cessation. No doubt, smoking is totally and absolutely catastrophic. Cancer, cancer, cancer. Heart attacks, sudden death, no doubt. But the question is, if smoking has been avoided, what about the alternative ways of the nowadays development? In my view, if we like to be ethical, we have to be based on real scientific data. If these alternative ways of non-smoking, nicotine use, but not smoking, are working, if the human beings like these alternative ways, and if the clinical data are indicative about the less risky effects against the human beings, then why not? I think FDA, and possibly EMA, I'm not sure EMA, but for sure FDA recently, based on this ideology, has chosen to recognize some of these products as possible alternative ways to the smoking usage. So, to make the whole story short, my narrative. First, we need clear data. We have data day by day, year by year. We have some laboratory data, some small trials, but as I have suggested in many ways to big industries related to these products, we need more clear evidence in order our, let's say, scientific interest to be satisfied about the rather non so much malignant effect. If we had seen that the alternative products, the products that are not related with the burn of tobacco, but with the heating of tobacco or the electronic products, if these products are getting less and less severe harm, I think this is a way to adopt and to advise all those who like to have a pleasure because of this habit. Going through this way, I think we could compromise between our ethics, our ethos, and the reality, because by the end, we have to recognize the reality. And to be honest with you, when I was some years ago in St. Petersburg, participating in a senior meeting of WHO, and I was listening all those seniors talking about smoking, okay, no doubt, salt consumption, and alcohol consumption, I stood up and I said, I would like to make a comment here, not as a president of ESC, but as a simple human being. After 3 hours discussions, I said, here, I'm listening all of you talking about smoking cessation, salt reduction, and alcohol full cessation, of alcohol consumption cessation. But I have not heard anything about the cannabis usage. Nowadays in the United States, from the west end to the east end, everywhere in all Europe, cannabis is getting more legitimate, and nobody is discussing about cannabis, but everybody is speaking about the catastrophic effects of alcohol, the catastrophic effect of any tobacco-related product, etc. So why? What is that a kind of hypocrisy? So that was my real approach to the issue. We have to be pragmatic, but still we desperately need, as a scientist, to see well-organized, randomized trials, large scale, to see the real effects, the expected real effects of these new products. Personally, if you like my personal view, absolutely believe that the effects of these alternative products are much less malignant versus smoking.
Thank you very much for this really stimulating approach. So, Dr. Farsalinos,
Yes.
it's your turn.
I think in this subject of tobacco harm reduction, unlike any other harm reduction aspect of our daily activities, let me remind everyone that the use of seatbelts and the use of helmets when driving a car or a motorcycle is a typical example of harm reduction in our daily lives, because neither the seatbelt nor the helmet eliminate the risk of being injured or dying in a car crash. They reduce the risk. And no one is telling you that you shouldn't drive your car unless you're doing something very urgent or you're going to your work. We all take our cars and go for a weekend with our family. We are all exposed to that risk. We take measures to reduce the risk, harm reduction, but we don't necessarily avoid the risk, although it's not a necessity to go and have a weekend with our families somewhere using our cars or going for a ride with our motorcycle. Condoms is a typical case of harm reduction. No one discussed about sexual abstinence unless you want to reproduce yourself and your family and have a child. Medicine is by definition, and medical practice, a harm reduction science. Why? Because with the exception of a few infections, you don't eliminate any disease. You treat the disease. When you have a heart attack, part of your heart is destroyed, is dead. You can't revive that, although we've tried to revive that. But you can't revive that. You will always be a patient with atherosclerosis. You will always be, for the rest of your life, a coronary heart disease patient. And we will do everything to reduce the consequences of the disease, to improve the quality of life living with the disease, to reduce the further progress of the disease. But these are harm reduction goals. They are not harm elimination goals. We will never eliminate the disease. So all these are perfectly acceptable, but harm reduction for tobacco is not acceptable. And I think that over the last several years, we are seeing a battle between idealism and pragmatism. You know, being realistic or trying to imagine how an ideal world would be without any traffic accidents, without any pollution, using only green energy and having enough energy at the same time, not like where the conditions we're facing today, having no one to smoke, no one being exposed to any other environmental or non-environmental risk factor, like, as Professor Vardas said, alcohol, red meat, sugar. There are many examples, but that's idealism, and we need to be realistic. You know, in the past, there was an ethical theory of consequentialism. According to this theory, any action is completely, and the morality of any action is completely determined by the end result, and not by the way in which you are reaching the end result. And this theory is the source of the famous phrase, the end justifies the means. And I think that in some cases, when dealing with tobacco control and tobacco harm reduction, this is what we are seeing. We are seeing that some people who feel that the end should be ideally the elimination of nicotine, not only tobacco use and smoking, because this is the debate today, let's be honest. No one is talking about tobacco or smoking. Everyone is, and I mean the authorities, the WHO, the CDC, even the European authorities, they're discussing about nicotine elimination, let's be honest. In the same way that in the past they discussed about marijuana elimination, but now it has been revived. The same thing happened with alcohol, with the prohibition in the US. We all know the results. We even see the results of alcohol prohibition today. There is a state in India that has banned alcohol use, and it's the state, I don't remember the name, but it's the state with the highest alcohol consumption compared to all other states. And everything is illicit. You know, and when you have illicit trade, you also have very risky products becoming available through the black market. So I don't believe that consequentialism and the phrase, the end justifies the means, is moral. It's not ethical. Why? Because it violates at least one of the principles of bioethics, and that's autonomy. Autonomy which is based on full information, reliable, balanced information, and providing consent. You know, it also violates the principle of justice, let's be honest, but autonomy is the main victim of this moral theory of consequentialism. And, you know, autonomy, but also justice, and that's an irony, was protected by the WHO, who is now, I think, is not acting very morally and ethically in the case of harm reduction for tobacco products. But the autonomy principle of bioethics and the justice principle of bioethics were protected by the Ottawa Charter of 1986 about health promotion. That was a WHO charter which said, basically, the basic principle was that we need to provide all the means and all the information to people to take control of their own health. And by knowing better for you than you, because that's the approach, you know, smokers don't know what they're doing harm to themselves. Of course, they can't quit because they have a very strong dependence, but if you think of using an alternative product, just because it's not ideal, you don't know better than us. We know about you better than you. That's the attitude. It also goes against the Ottawa Charter of 1986. It prevents people from being autonomous, from making decisions based on their own preference, let's say. Even if it's not the ideal or the best approach or the best decision, we need to give them the tools. We need to provide them with balanced, reliable information. And that's how informed consent is created. There is no other way. By creating and propagating misperceptions, misinformation, miscommunication, somewhat exaggerated messages that are not necessarily truthful. They're not even lies, but they are, you know, half-truth is basically a lie, let's be honest. You're not creating an informed consent and informed decisions. You are basically preventing everyone from having from making an informed decision. And the problem is that in some countries, they are depriving people of the tools to improve their health. There are Millions. We have more than 1 billion smokers today. Today, after 60 years of knowledge, it was in 1962 when the Royal College of Physicians, the UK, released their first report about the harmful effects of smoking. It was in 1964 that the Surgeon General in the US released their report about on smoking and adverse health effects. People know and are aware of the adverse effects of smoking for decades. Still, we have more than 1 billion smokers. We need to think, why do we have 1 billion smokers after 60 years of knowledge? What is wrong with this situation? Why have we failed to eliminate smoking? What do people want? Why do they smoke? Why don't they quit? Why don't they go to a smoking cessation center, even in countries that are in which the cost of going to a smoking cessation center or the cost of medications is fully subsidized by the state? They pay nothing. Still, they don't want to go there. When you ask smokers, why don't you visit healthcare professionals for quitting? The main reason, the main response is that they don't think smoking is a disease. They think of smoking as a bad lifestyle habit, a bad choice that they made in their life. And they need to change their lifestyle because it's a daily activity. They don't consider it a disease. But we, not only the healthcare community, but also the policymakers, are trying to treat smoking as a disease. And you know how much hurdles this creates in providing alternative products to the smokers. And these are legal hurdles. For example, you can't have any product claiming that it promotes smoking cessation. It must be approved as a medication. So even if someone produces something that wants to sell it as an alternative to smoking in order for people to quit smoking, they can't use that claim. They are illegal when they use that claim. They break the law when they use this claim. So this creates a hurdle in informing smokers, for example, that this product will help you reduce or ideally quit smoking. Well, where is the ethics in that? Why do we need to lie to the people in order not to break a law? Well, the problem is the law. And we shouldn't lie to the people. We should adjust our policies. We should adjust our messaging, our communication, by addressing the need of the people. If we don't understand why people keep on smoking, why they cannot quit, why they don't want to get medications, why they don't think that smoking is a disease, if we don't answer to these questions, we will never be able to make policy decisions that are going to be for the people, that are going to address the needs, the preference of the people. So I think that there's a big gap between policymakers and regulators and the citizen, and what the citizen wants, what the citizen feels about this problem. And the gap, I think, widens all the time, and that has created mistrust, as David said earlier. A very strong mistrust for the information or the communication from the government or from the authorities about health issues. And that also includes the pandemic and COVID, as he very clearly mentioned. That will include even other health issues. It will also include issues where there's nothing wrong with the messaging, but when you have mistrust towards an authority, that will expand to all issues. And that is going to be very harmful for public health. So I think that the moral way forward is always speaking the truth, providing balanced information based on the totality of evidence, and not cherry-picking evidence and exploiting parts of the science, misinterpret them, mispresent them, and use them because we have a specific ideology and a specific way of understanding what the end is, and we're going to use every means in order to reach to that end. That's what I think is not ethical, and we should work the other way around. Thank you.
Thank you very much for this excellent presentation, this excellent intervention. Actually, I expected some comments on the law's role from Professor Sweanor. I heard them
From me.
Dr.
not a lawyer,
Dr. Farsalinos, but still, I believe that the intervention of Professor Vardas put very clearly some ethical questions, particularly regarding the need to associate our ethics considerations with scientific data and the relevance of science in this topic. But still, I would like to ask you just a small, if you allow me, I'm only a moderator, so kind of psychoanalyst. My role is rather to facilitate the discussion, not to proceed to my own speech or whatever. But I would like to hear from you, and first from you, Professor Sweanor, what is your view about the role of law in all this discussion? I mean, do you agree with Professor Farsalinos and his point?
Yeah, and when we look at the role that law can play, I mean, obviously we look at things like regulation, we're writing laws, legislation. When we have countries, including my own, that pass a law saying it's illegal for a company to tell people the difference in risk between products, you know, that is so far away from an ethical framework to say we are going to force the public to be misinformed about something that could save their lives. And we see this in country after country. Who's writing those sorts of laws? When we have regulations that protect the cigarette business, like the FDA law, that makes it very difficult to have any alternative to cigarettes, where's the ethics in something like that when you come back to the framework about what should we be doing to inform people, to be able to make better decisions, and to allow them to act on that information? You know, you want people to have the information they need and the ability to act in terms of the products or the services that are necessary. And we limit that. So we need to look at how we draft those laws. We also have to look at the role that litigation can play on some of this. You know, there's reasons why some of us have been involved historically in suing cigarette companies because of them not living up to their ethical obligations. How do we apply that now in other cases to those who've been misleading the public again? You know, we had the problem of cigarette companies trying to convince people that cigarettes weren't as hazardous as they truly were, and that caused lots of harm to the public. We now have entities that are trying to convince people that alternatives to cigarettes are no less hazardous when they clearly are massively less hazardous. And again, as a result, people are being harmed. You know, what's the duty of care of these organizations? Is there a role for litigation in something like that? So I think we can play a huge role, but I think we just need to come back to these fundamentals that you need to deal with truth. There has to be justice. You have to understand the lived experience of the people you're trying to help. You have to meet them where they are. You have to find ways to empower them to make better decisions and allow those decisions to actually happen.
Okay, right. But I guess the role of state is not only to enact laws, that it's more wider. And so I would like to hear from Professor Vardas, for example, how the state should intervene in this with no legislation, with no need for legislation, how to intervene to nudge people to quit smoking with other policies.
First, I am not in favor of radical decisions. it's extremely risky to sideslice human beings, smokers versus non-smokers, etc. So we have to follow a smooth but clear policy. In my opinion, the scientific associations, even the healthcare authorities in this country, are doing, during the last 30 years, huge efforts to make clear to the population about the harm results of smoking. I am not sure if any in this country is ignorant about these risks, correct? Okay. According to the results of cardio research, a small but active society that I'm leading here in Athens, very recently, last week, we came out with some important statistics. So, from one day snapshot in the whole country cardiological clinics, we scan all the hospitalized patients. And we found, in the cardiological clinic, correct? And we found that 27.5% of those, despite the disease, were still smokers. Okay? So this is a very, very fresh announcement. I have not announced this finding yet, officially. So 27.5% this is not a general population, okay? This is hospitalized patients in whole country one day because cardiovascular diseases, okay? So what does it mean? It means that all those continue to smoke despite the well-known harm effects to their health because of smoking. So, I'm not sure that the country, its country, could move ahead or should move ahead to more tough measures. We know that the insurance companies are much more tough in their decisions, correct? Okay. On the other hand, of course, we have to continue explaining and advising the population, no doubt. And who knows, progressively, because the change of the population, the change of habits, the change of mindset of the population by the years, possibly the population is going to go alternatively to less harmful choices, correct? Again, it is highly possible, but not proven yet in a large-scale trial that these products of tobacco heating or nicotine consumption are not leading in a such high number of cancer, lung cancer, heart attacks, etc., or urinary cancer. Possibly, a large-scale trial could lead to revealing results from the comparison of the two products, okay? That's why I'm stubbornly suggest to the big companies to compare the results of the new products versus the traditional smoking.
Thank you. Dr. Farsalinos, I really enjoyed your point on consequentialism, which is also, utilitarianism is an aspect of that moral attitude, and utilitarianism is very popular nowadays, particularly in public health issues. But I enjoyed also your point on the autonomy and the informed consent rule. So my question to you is whether you think that in all this discussion about the tobacco reduction, there is an implication, or there is something that suggests a kind of return of medical paternalism.
Yeah, I think you've said it really to the point. As I said, it's like I said, we know better than you about you,
Yeah.
you know, and we are more capable of making decisions about you without asking you if you like or if you want to follow this decision or this approach. It's very accurate. It's medical paternalism. And also coming from the authorities and as an expansion from the regulators, because they follow such an advice.
Is that a resurrection of
I think
medical
that
paternalism?
we are definitely seeing something like that. We are seeing people not participating in decisions made about them. We are seeing some form of enforcing decisions by using punitive measures, basically, by punishing them with a complete lack of empathy. Let me give you one example that we were discussing yesterday with David.
Yeah.
Psychiatric patients. You know that in psychiatric patients, smoking prevalence is extremely high.
Yeah.
Extremely high. And there are reasons for that, you know. It's not coincidence. We did a study and we presented some preliminary data yesterday here. 68% of the more than 1,000 psychiatric patients in the Athens Psychiatric Hospital are smokers. 68%. It's more than double, it's almost 3 times the prevalence rate in the general population.
Heavy smokers.
And
Heavy
most of them are heavy
Heavy.
smokers too. Yes, they are daily, regular smokers, and most of them heavy smokers. And there's a reason, you know, because smoking is being used as self-medication for them. But the thing is that there is a law which prohibits smoking in psychiatric wards. And it makes, you know, no provision for providing them alternative products, for discussing them about ways of coping with smoking or reducing smoking. Nothing. You just cannot smoke there, you know. And these are not, you know, the general population. Okay, you can punish the general population, supposedly. But what about these people who have mental health issues and smoking, you know, relieves some of the pressure from their mental condition? You know, we need to have more empathy. That's what I think.
Right.
I think that the regulators and the authorities are missing empathy. Also, I wanted to comment on that Professor Vardas said. I fully agree that we need to focus on science and use scientific evidence. But what's the burden of proof? If we set it too high, it will become unrealistic. For example, if we want to use epidemiology and hardcore epidemiological endpoints in a randomized controlled trial, we know that smoking takes 10, 20 years to get to the point of developing disease caused by smoking. So we need evidence that it is extremely hard to be produced. Of course, we can use other kind of evidence, like, for example, look at secondary prevention, yes? So after the development of the disease, where the second heart attack, for example, is going to happen much sooner. But still, we're talking about huge projects that cost a lot of money, and only a few companies can cope with that cost. And that's the big tobacco companies that we are all blaming for being unethical. So we may reach to a point that we are creating a monopoly to the people that we blame, the tobacco industry, and it's not good to have monopoly for these products. We need product variability, we need product availability, we also need independent manufacturers. So yes, we need science, but we need to set the burden of proof to a realistic level, so that we will have more players into this. We will have more products that will create competition, better products, safer products too, so better performing but also safer. So the best case scenario for the smoker. But first of all, we need to understand smokers. We need to understand why they can't quit. And we know that from the evidence. You know, quitting smoking is a very hard thing to do. You know, it's not just choosing your breakfast in the morning. It's extremely hard. We know that. And unfortunately, medicine has failed to produce very effective smoking cessation medications. If you look at the best options that we have here, the best oral smoking cessation medication, it may have a quit rate of 40–50% during the first 2–3 months that you take the medication. But if you look at 1 year, success rate drops to 20%. It drops to 20% even among people who are highly motivated to quit. There was a study with the varenicline, the best smoking cessation medication we have now, among people with already established cardiovascular disease, with a heart attack, that they were smokers. And the success rate in those people was 19.2%. So 8 of the 10 smokers with heart disease were unable to quit using the best available medical choice that they had. So what is harm reduction? Harm reduction is not about substituting for all the other measures we have to promote smoking cessation. It's complementing, it's supplementing the other efforts. So it's an additional tool, and the reality shows that we need these additional tools. We can't just use what is currently approved and then have no other option. We've seen that this doesn't work for the majority of smokers. So this is also a moral aspect. Are we telling them use everything that is approved, or your only other option is just to quit smoking? Or approach with caution, but provide the information that we already have with the unknowns about these alternative products? That's the question.
But let's understand everything at this point too in the context of autonomy and informed consent, not in the context of a new medical paternalism.
Exactly. Exactly.
This is the point from an ethical point of view.
Exactly.
So maybe you kept some notes. Maybe you have something to comment on this point.
No, I think
I would like to hear, for example, do you believe that from the point of view of human rights, do we treat fairly the tobacco companies?
No, I mean, whether we should treat them more harshly or less harshly is a question. I think you have to use a framework to say what is it we're trying to accomplish. I think tobacco companies could actually be held to account in an ethical framework and possibly a court of law for not doing more to push the agenda for alternatives to their cigarettes. I mean, they know they're selling a tremendous number of cigarettes to many, many millions of people, a very large percentage of whom are going to die as a direct result of that. They know that there are less hazardous alternatives to these products. Their own science makes this very, very clear. And yet, when you have governments put barriers in the way, they say, okay. When anti-tobacco people, anti-nicotine people attack the products, they sort of say, all right. Well, meanwhile, they're making billions of dollars continuing to sell cigarettes. Is there reliability there? Is there accountability there? And I think that raises ethical questions that are very interesting. And there was a judgment, I think, just yesterday in the United States from a court holding Altria responsible for having not moved with less hazardous products. I mean, is that something that could kickstart a real change here? Because you've got a very risk-averse industry, and they happen to make a fortune selling cigarettes. Could we see a change in their behavior? Would there be a change in behavior of some of the health groups if they were held responsible for misinforming the public? What about countries that have constitutions, charters of rights that guarantee a right to life, that guarantee a right to free speech, truthful communication? You know, where are the actions there to go after those who are not giving accurate information, people who are not having access to it, people whose lives are threatened because of the absence of alternatives to their cigarettes? I think there's a range of areas that we could move in, and I'm hoping we're getting to a tipping point where we're going to start seeing some of that really shapes this field. and makes an awful lot of the battle we've had to date of the sort of the moralism on nicotine irrelevant, because we've now moved into courts of law, we've moved into legal, ethical issues that are much, much broader than just this issue.
Right. Okay. Now I believe that I can take one or two questions from you. Who wants to? Yeah. Please go ahead.
Thank you. Very interesting discussion indeed. I just like to pursue the propensity to require scientific evidence in making decisions. I'm sure everyone agrees that our decisions have to be evidence-based, but I've always believed that evidence-based medicine can also, it's both a boon and a bane. It can be a bane if, as also mentioned earlier, we require such a heavy, high burden of evidence before we make some decisions. That's not how sound medicine has actually been practiced all these decades. Professor Vardas, if you recall, physicians have been using antihypertensives heavily in the late 50s, in the 60s, without any evidence that it can really improve outcomes, that it can really prevent heart attacks, strokes, and then improve survival. It was only during the 80s and 90s when all this data came out. But physicians were confident that they were improving the long-term outcome of a patient if they bring down the blood pressure. Okay, so similarly, with the use, for example, of alternative tobacco products, if we can accept mechanistic goals or surrogate endpoints, not hard endpoints, but surrogate endpoints, which can give us that level of confidence that if we're able to improve the surrogate endpoints, we're able to reduce the risk of exposures to harmful and potentially harmful elements, if we're able to mitigate the other medical and other cardiovascular risk factors, there's very good reason to believe that it will certainly improve the long-term outcome of the patient.
Thank you. Professor Vardas, you want to comment?
I agree. So we have to agree upon some realities. We have already some evidence. We have some evidences coming from laboratory studies related to these products. And that's why I guess, FDA has already accepted. As I said, FDA recently has adopted a policy which is not such tough. They have accepted the usage of these products as harm reduction products versus smoking. Okay? Great. So I agree with you. If I have to choose, and I think I was stated before, if you had asked me, so sir, I cannot stop doing something with my mouth. Can I use smoking? Can I use cigars or these alternative products? I would say, okay, please use these alternative products because already we have some evidences, according to FDA, but according to also to our knowledge. Okay, talking about clinical trials, properly organized clinical trials, I would like to remind you, but also to Dr. Farsalinos, that nowadays the pharmaceutical companies, the big pharmaceutical companies, of course, not the very small, are spending averagely for one well-organized clinical trial something between $500 to $1 billion or euros. This is the average price for a well-organized trial. And be sure, I don't know if you have a physician background or not, but be sure that many clinical trials nowadays in our cardiovascular field finally have been proven negative. The money spent is for nothing. But still, we continue to organize big clinical trials. So what I have suggested many times as a thinker even to all those discussions is to encourage big companies, big tobacco companies, and big companies organizing these alternative products to spend money for a large-scale, at least one large-scale trial, because in the case of good results or negative results, for us, the cardiologists and the physicians, the whole situation will be much more clear, ethically talking, because we need to be based on some ethics. I recognize what Dr. Farsalinos said. All the times, but that was the case just in general, also in the European Union discussion about medical devices. It was so difficult for the European Union to take a decision for pre or post-market evaluation, because pre-market evaluation means that all the small companies should be killed.
Yeah, yeah. So,
Yeah, it's a big discussion. Yeah.
but first, I think, Dave, you have something to comment on, and then you can.
Yeah, I mean, the question of what level of evidence, in law we talk about balance of probabilities. I mean, we never have absolute knowledge on anything. The question is, when do you have enough knowledge to justify acting? So from a regulatory standpoint, a legislative standpoint, that would be the question that we should be looking at in terms of alternatives to cigarettes. But then there's an ethical question here too, an ethical aspect in that what information should you be telling the people whose lives are at risk? What level of certainty do you need? And that's the idea of respecting their autonomy to say, here's the totality of information that we have to date about the relative risks of these other products. It's not up to me to decide whether snus is a good answer to your smoking. It's up to you. I'm empowering you as a consumer. And we have really messed up on that, globally because of the level of misinformation. The people who do not believe these products are less hazardous. And it's not just vaping products or heat not burn products. This has historically been the case on oral tobacco products like snus and moist snuff. It's been the case on pharmaceutical nicotine products. People are horribly misinformed. And someone needs to be accountable for that, to say people can only make as good a decision as the information available to them allows. And it is simply wrong to fail to give them the information they would need to make an informed decision, even if it's a decision I might not personally make. It's their life. They should have control of that.
Yes,
well, I think that
please.
David mentioned the example of snus, which is a product with the best long-term epidemiological evidence in humans. We're not talking about toxicity studies. We're not talking about cell or animal studies. With the best level of epidemiological evidence for decades, and the product is banned in the European Union. It is banned. It's not just that the authorities are not endorsing it. The product is banned. We can sell cigarettes, and you can find cigarettes everywhere in Athens, but the companies cannot sell snus in Athens or in Greece or in Europe, with the exception of Sweden. That was the only exception. So you see that even when you have a very high level of evidence, epidemiological, long-term evidence, we have evidence that snus users, even long-term users, more than 20 years users, or users of more than 7 cans of snus per day, have the same risk of developing stroke or a heart attack as non-smokers, non-users of any product. We're talking about evidence showing 0 additional risk compared to not being a smoker. And the product is banned in the European Union.
So maybe scientific evidence
Is not enough.
Is not enough.
Yeah, but I also think that using pharma regulation the same way as approving a medical product, a medication, for a consumer product is not the right approach. For example, many artificial sweeteners or natural sweeteners have been developed over time, but we didn't expect of evidence of reducing mortality or reducing the prevalence of diabetes until they were released in the market. For example, today we have the natural sweetener stevia, and it's being used widely. I also use stevia instead of sugar, yeah. But did we wait for evidence to show that our mortality will be reduced, our risk of dying or risk of developing diabetes will be reduced? No. It's a consumer product. Of course, you will have physicians advising you that, it's better to use it, but even physicians are not going to use it as a medication, They're using it in a different way, but what's even more important, the consumer is not using it as a medication. You won't prescribe 5 puffs of an e-cigarette 3 times daily after lunch, breakfast, or dinner. It's not used like that. These products are used based on self-preference. They are used according to the individual needs of the smokers in terms of nicotine intake, in terms of what kind of experience they expect. Some smokers want throat heat. Other smokers don't like throat heat. Some smokers need a lot more nicotine than others, and that's why they adjust their puffing patterns. These are self-preference criteria through which they're going to use different products, and that is why we need different products, because the criterion for choosing something that fits your own needs is quite unique for each smoker. And if we use the pharmaceutical regulation, then we're going to have a very small number of products who are going to have the necessary funds, to prepare all these big clinical trials. Of course, I'm not suggesting that we don't need evidence. Of course, we need evidence. But I don't think we should approach the issue of harm reduction products with the same standards and the same burden of proof as for pharmaceutical products, for example, or even medical devices.
Okay, thank you very much. So I believe, I don't know if we can take one last question.
Be very brief, though,
Yeah.
because we are very late.
Yeah. Yeah, but still the discussion is very interesting, I believe, for everybody. Okay, one last question. One last question. Anyone? The best. Yeah, the best.
Thank you. Dear professors, your opinion sounds very progressive, especially Professor Farsalinos. And I'm very delighted with all of your speeches. But it seems to me that many of these issues that we are discussing now are in the plane of rhetoric. But I wanted to ask you, what do you think about the role of patient communities in spreading the message of harm reduction? For example, in one of the ACC networks media, the patient community discusses the heart diseases. They tell their stories about some heart surgery or something to inspire other patients to follow a similar path. What do you think in this way, in this framework, about the harm reduction strategy?
I can start. I mean, yes. I mean, when we look at how attitudes have changed on a great many things, it's people whose lives or well-being are on the line, or the people they care about, who take initiative. When we look at, how did we get women's rights? How did we get gay rights? How did we get less discrimination on the basis of race? How did we get workers' rights? I mean, people, you have to push for something. And patient groups can be very valuable for this. And this is also an area where information helps, like the patient groups, such as family and friends of people with schizophrenia. If they knew, the rates of smoking and why, and the idea that these people could get nicotine in a way that didn't kill them, but they're not being allowed to, I would imagine some people could get very angry and families and friends of people whose lives are on the line have a long history. I mean, we look at what happened on AIDS, the politics of that, a long history of changing policy. So I think it'd be incredibly valuable when we look at the broad range of people who are using nicotine as a form of self-dosing or are just users of nicotine, should they have a right to proper information and a right to alternative products. And I don't think it's any different than the battle we've seen on human rights on a very wide range of other issues, whether medical or otherwise.
Yeah, clear.
No, the only issue is that these patient groups are going to be in a big discrepancy with what the authorities are saying, and as you understand, that will also create a confusion, whom should I believe? But I think that this is a very valid point, and I think that personal experience should definitely be communicated, and unfortunately, sometimes people will trust other citizens more than the authorities. It should have been the other way around, but unfortunately, this is what's going to happen. In that case, it will work. But there must be no, in my opinion, clash between what the authorities and the policymakers are saying and what citizens are saying or are believing. There must be a connection, and we must find the tools to understand what people need and why they're taking the behaviors and the attitudes that they're using.
Okay, so that's it. Thank you very much for attending. It was a really inspiring discussion, I believe. I'd like to thank our panelists. We had outstanding interventions. Thank you all, and sorry for the shorter time of lunch.